The chairpersons for this session are Dr. M. Mariappan and Dr. E. Sivabalan sir. Dr. M. Mariappan sir, Professor in Department of Psychiatry, Chengalpattu Medical College, Chennai, Mr. President,
Indian Psychiatry Society in Tamil Nadu. He has got 24 years of teaching experience in psychiatry since 1997. Examiner in psychiatry for the Tamil Nadu Dr. MGR Medical University, Kerala University of Health Sciences and other private universities. He has presented guest lectures in state zonal conference, published papers, presently the Chief Executive Officer in charge of State Mental Health Authority, Tamil Nadu. Our next chairperson is Dr. Sivabalan Ilangovan sir, Professor in Department of Psychiatry, Sri Balaji Medical College, Hospital Krompet in Chennai. He had completed his MBBS in KAPV Government Medical College, Trichy, and his MD Psychiatry in Government Stanley Medical College, Chennai. He is the University Gold Medal winner for MD Psychiatry by Tamil Nadu Dr. MGR Medical University, associated with Dr. M. Tirunavukkarasar, Professor and HOD in 2 textbooks of psychiatry named Schizophrenia Today and Mood Disorders Today. Advisor and resource person in Tamil Nadu Government School Education Department in conducting many training programs for government school students as well as teachers. I now call upon the chairpersons to talk a few words about the speaker.
Good afternoon, everyone. And the topic, the interviewing techniques. And I know Dr. Aravindan for the last 20 years, his abilities in teaching, his way in interacting with the postgraduate students and teaching the skills and knowledge of psychiatry. And this one topic will be necessary or will be essential for the students in the first 2-3 months of their course. When they enter the psychiatry from after finishing their undergraduate course and entering the psychiatric institutes, they should be trained in the interviewing skills. And I am very sure Dr. Aravindan will be the best person to teach you about the nuances of the various interviewing techniques in psychiatry. And a versatile teacher, humanist, and a very simplistic person and a dedicated teacher in the field of psychiatry for the last 20 years. And I request my co-chairperson, Dr. Sivabalan, to formally introduce the speaker, Dr. Aravindan.
First of all, I honored to chair a session for my teacher, Dr. Aravindan sir, and along with another teacher, Dr. Mariappan sir. I thank the organizing the committee for giving me the opportunity. First of all, the psychiatry is differ from other field of medicine is because of the interviewing skill we have. Psychiatrists themselves, they differ from other psychiatrists. How empathetically and how sensibly they interview the patient. You become successful in your career, it is not because of your diagnostic skill or management skill. It is only how empathetically you understand the patient. That is very important. That is the purpose of the clinical interview in psychiatry. Understand means we have to understand holistically in all dimensions, biologically, psychologically, and more important, socially. But often the social part we missed. We didn't give much importance or we not at all consider the social part in our interviewing technique. So in this aspect, I find Dr. Aravindan is a right person to talk about this particular topic because he is a very social person. He always see individual as the unit of society and he always blame the state or society for the individual health issues. So I honored to invite Dr. Aravindan sir. He did MBBS, DPM, recently completed MRCPsych. His area of interest is neoliberalism, deinstitutionalization and mental health policy, sustainable mental health system in new liberal era, ethics in human rights and psychiatry. I welcome you, sir.
At the outset, I would like to thank the organizing committee for giving me this opportunity to stand before the young psychiatrists and also the chairperson for the kind words. So, the morning we had two sessions. One was about the belief which is true and which is not true. The other was whether to do or not to do, about the phenomenology and concepts and other things. So, as a psychiatric postgraduates, the postgraduate training, so the initial part will be the how to go and talk to the patients. So, how to gather information. So, again the theoretical aspect will be to collect informations about what are all the things we have to read, the phenomenology, and then what the concepts we have to read in the first year. But in a PGCME, so having a topic like, say for example, interviewing techniques in psychiatry. So, it's good that the organizing team had included this, because this is extremely important, how as a psychiatrist you are going to gather the information when a person comes and sits in front of you. So I could remember my post-graduation years day in 2001, and when I was a postgraduate in the IMH. So I was interviewing a patient, and then I was stuck in between. I went and spoke to my assistant professor, then Dr. Muttalagan. He is no more. And I told him this, sir, I am not able to diagnose. That was the statement I made. I am stuck. So immediately he said that, so you started to diagnose. Did you start to diagnose? So why did you start to diagnose? So I got baffled. I am not able to understand what he said. So my role as a postgraduate intern at that time is, when a case is given, I have to take the history, diagnose, and then go and present the case to the assistant professor. So he then made a statement. So you speak to that person as you communicate or converse with any other person as a friend. So I think I'm not able to understand at that time. So he was talking about communication skill. He was talking about various skills which is very important being a psychiatrist. So don't look at the diagnosis initially. That was a statement he made at that time. I was not able to understand then. So this is the first chapter in Oxford textbook of psychiatry. Many a time I ask the young psychiatrist who enters the field of medicine, go and read this first chapter first, before entering into neuroanatomy, neurophysiology, and then phenomenology and other things. So it starts with these lines. So it's difficult to be a psychiatric patient, right? But a good doctor can make it less so. So but the chapter is extremely important, because in no other field of medicine you have a chapter with these two titles, on being a patient. It starts, the previous edition in 2003, Oxford textbook of psychiatry starts with the title, on being a patient. The recent editions it has changed, being the patient's perspective. So as a clinician, when you speak with the person who sits in front of you, so you have to incorporate what exactly is going, what views are he is having, what are the beliefs he is having, what is his perspective, to get a better understanding of what he is going through, which you are going to incorporate in your management plan, in the follow-up and everything. So without that perspective, what exactly he has, so are we going to be a good clinician first? Whether it is going to hamper the decision-making process, whether it is going to hamper your diagnostic process, whether it is going to hamper your management process, that is what we are going to listen now. So I am going to talk about three usual scenarios which everybody would have seen, the day-to-day things, which is not about a specific OPD. So I've been in medical college since 2004. 2003 I completed my DPM, and 2004 I've been in medical college and postgraduate training institute since 2007. The first scenario is an intern is sitting and a patient comes. He sees the notebook in a review OPD. The patient has not come to the OPD for 2 months. And then the intern reacts. So he interviews. He says, ஏமா மாத்திரை விட்டுட்டியா இந்த வாட்டியும்? மாத்திரை விட்டுட்டீங்கன்னா பிரச்சனை வரும் தெரியாதா? மாத்திரை இந்த அடுத்த வாட்டி நீ மாத்திரை கரெக்டாக வாங்க வரலன்னா இனிமேல் மாத்திரையே கொடுக்க மாட்டோம். So then he writes the medications, He assesses the phenomenology, what are the symptoms is relapse, and then he sends the patient home. The second scenario is about a patient who has multiple consultations, who comes with severe palpitation, chest pain, and he thinks that it's a heart attack. And he comes to the OP, rushes to the OPD, and then the intern says, சார் எனக்கு பயமாக இருக்குது, ஹார்ட் அட்டாக் வந்துடுமோன்னு பயமாக இருக்குது. எத்தனை வாட்டிப்பா அவனுக்கு இசிஜி எடுக்கிறது? அதெல்லாம் ஒன்றும் இருக்காது, இந்த மாத்திரை எழுதுறேன் சரியாயிடும், மாத்திரை போடு, ஒன்றும் பிரச்சனை இருக்காது. And he sends the patient home. The third, an intern presents the case to the professor or assistant professor. The patient was diagnosed to have bipolar depression, and then patient is to be started on lithium. So the patient is sitting, the intern comes back, writes the medication, இந்த மாத்திரையை சாப்பிடுங்கம்மா, பிரச்சனை முடிஞ்சு போச்சு, சரியாயிடும், 2 வாரம் கழிச்சு பார்க்கலாம். These are the scenarios in which we are going to travel when we talk about this thing. So there are 3 circles. So one is the person, the first one. The second is the process, and third is the content. So when a person sits in front of you, apart from you evaluating the person who sits in front of you, the other person also evaluates. So in a hurry of taking history, how you are going to view the person who sits in front of you? So am I curious to ask questions, who is this person who sits in front of you? Why is he here? Is he a cluster of symptoms who sits in front of me? Or a person with neurochemical imbalances? Or is he a person who has some problems which I am going to discover? I am going to help. So what is his perspective about his problems? What are his views? How am I going to travel with this particular person? The second thing, process, which we are going to discuss today, is about how we communicate or how we gather information and how we get there during the process of interviewing. This is extremely important because we know about the content. That is what the healthcare professionals or a psychiatrist communicate. So we pick up hallucinations, we pick up delusions, we pick up obsessions, and then we treat. And how we are communicating, that is what is going to be the topic of discussion today. That's the process of the interview. The traditional models in medicine or psychiatry field of medicine, traditional models of teaching, the history what we take, we can add MSc there. That is the content of the medical interview. From the reason for consultation till your insight, and then you summarize. That is the content of the interview, where you gather information. But in the traditional models, which is not included, the process of the interview is not included. So there is another model called as the communication model, which incorporates the traditional model of history taking, and then it's an alternative framework where a list of skills are being taught to the doctors, how to go through or how to gather the information in a collaborative way, get the information and then discuss the information, and then go in for the next step of management and treatment. So what happens is, when a student disregards the communication process skills learning and then use the traditional history taking method as his guide to communicate. So a person knows how to take history and then use that content in his information gathering or how to speak with the patient, then the history taking becomes a tight structured, closed interviewing techniques, checklisty symptom reevaluation, and then at times it reaches nowhere, and then it is not collaborative. So is there a place for a patient's perspective in a traditional history taking format? No. So we don't have a space there in a traditional history taking format, but the newer format is an expanded framework where we gather information. That is the process skills. The first part is a process skill, and then when you see the content of the history, The right hand side, you can see the patient's perspective, which has to be incorporated in your content skill. So the three scenarios, I'm going to take you back to what is person-centered interviewing rather than doctor-centered or symptom-centered. So we are shifting towards person-centered interviewing. So when a person comes there and sits in front of you, he might be extremely hesitant. He has a lot of questions in his mind. He might be anxious. He might be restless what this person is going to speak or is going to do. So we as a clinician, we are in the dark. So we don't know what this person is going through at the time. So we have a compass in our hand which guides us to the dark room. So what is the compass we are having? So it is a realization that we are there to help this particular person who has sought the care. So in a person-centered interviewing, the clinician views the interview as a cascading series of unique moments in time in which biology, psychology, culture, even spirituality, intimate relationships, family dynamics of a patient intersect to create the unique person before us. The goal of the clinician is to understand this uniqueness and to help our patients to better understand their strengths and weaknesses and to learn how to navigate their complex human matrix affectionately. So our interviewing technique, so why are we talking about this particular person-centered interviewing technique? So as a clinician, our interviewing skills, the techniques and strategies will be enriched by our efforts to see the world through the patient's eyes as well as our own. So we have to collaborate with the patient, his understanding, his views and his problems, and then we share some of the suggestions in person-centered interviewing. So again, இதுதான் நீ சாப்பிடணும், இதுதான் நீ எடுத்துக்கணும் அப்படின்னு சொல்றதுக்கு முன்னாடி, it is a perspective that gently reminds us to understand what the person seeking our help wants us to provide before trying to provide it. So one important part about person-centered interviewing is the person is not viewed as a problem, but as a unique individual filled with solutions. So we have to find out the solutions, sitting and discussing with the patients. So there is also humbleness in patient-centered, person-centered interviewing, where it is the wisdom that even at our best, we do not know all the answers, for we do not know all the questions. So when I ask about why do you want to interview, what are the goals of interview, apart from making a tentative diagnosis or collecting the symptomatology, there are a lot of goals in your clinical interview, right? How to engage, get sound engagement with the patient. How to collect that database about what exactly is going through the content of the interview. So why should I talk about being compassionate, being understanding? Why should I talk about engaging with the patient? I have a manual, I have a diagnostic manual in my hand, I have the criteria, I can ask certain questions and come to a diagnosis. But the goals of the interview includes various aspects. To collaborate, delineate set of practical problems, collaborate and develop a tentative plan. So they use the word collaborate. So this is new. I have to sit and collaborate with somebody. So to begin the healing process, again new, right? So we have to heal somebody, to how to begin the healing process, and then to instill hope. The first chapter in the Oxford textbook of psychiatry ends with hope. Please go back and read if you haven't read that chapter. So they gave a map of the interviewing process, right? So apart from the data gathering here, before the data gathering is the engagement process, how you are going to engage with the patient. There comes understanding of the patient. Why should I sit and understand somebody? My role is not to understand. My role is to diagnose. But to come to the assessment and diagnosis, you have to understand this person, and then that is cyclical, and coming to the treatment plan, triage and management plan. So, understanding the person as a unique person and the clinician's ability to see the patient's view of the world and recognizes the patient with fear and giving hope. So again, this is going to be the framework. This is the history. Everybody knows what we are going to talk, how we are going to initiate the session, how we are going to gather the information, building the relationship, and giving the information to the patient, and then ending with the closure. Just before the closure is the explain, and then we plan the management. So these are the 6 tasks we have been doing, right? We gather the information, and then we write the medication and send the patient outside. So this is the new last month published in British Journal of Advances, 2023 January. It talks about the tasks for stages of clinical interview, where we all know what exactly to begin and then what we should ask, and then. So this is again a different thing. This is an information gathering skill which we are going to talk to gather the information and then how to collaborate with the patient. This is what we are going to do. This is given in the recent edition of British Journal of Psychiatry Advances. Initiating the session when a patient comes, right? I always talk about the chair, right? So in my post-graduation days and after my post-graduation days, as I was working in hospitals, when a patient comes and sits, so they always say that's the doctor's chair. That is not the patient's chair, right? The doctor sits in a different chair and patient sits in a chair. So what's in a chair, right? So in Western field of medicine, they always say that you have to sit in the same level with the patient, right? That is what they teach there. So அங்க உட்காராதீங்க, உள்ள நுழைஞ்ச உடனே பேஷண்ட் கிட்ட நம்ம சொன்ன உடனே how we are going to initiate the session. So we have fought hard to initiate the session by sitting on an equal plane. Right? We have to fight for the same chair. So what are the objectives we are going to do there? Where do we get to? That is the objective of how to initiate the session. So again, supportive environment, right? So somebody is pushing the patient, and then how we are going to make the environment comfortable for the patient to gather the information. So establishment of rapport, and then identify the problems. This is skill, and then how to prepare. So most of the postgraduates will be extremely worried that they have been given 3 cases or 4 cases. They have to complete the case. So the attendant will come that there are 2 cases pending, right? So I will be more preoccupied with completing this case and then going and seeing the other case. I will be filling up all the last summarizing and then diagnostic formulation I have discussed, and then I got the assistant professor got angry, and then I'm extremely worried about this case, and the patient sits in front of me, the next patient, right? I'll be writing the case sheet, the previous case sheet, right? So the patient sits there for 5 minutes. I will not be speaking at all. I will not be looking. So the patient will sit there extremely worried what this person is doing in front of me. So the preparation, whatever task you have been doing, just close it and greet the patient who sits in front of you. This is extremely important. So these are all the simple things which is extremely important, because you have to see what this person is going through his eyes, right? Just imagine, just imagine, turn that angle towards a different thing. Somebody is sitting in front of you and you are going and having a consultation. The doctor does not speak. He sits and writes for 10 to 15 minutes. What goes through your mind at that time? So there are 3 related skills in this particular initiation of the session. First is the opening question, and second is the listening skill, and then you have to screen and then go into the agenda setting. So opening question, who is going to ask the question? At times patients speak, but at times the doctors speak. So what kind of questions I am going to ask, right? So the teaching in psychiatry is always ask an open-ended question. Who is this person? Why is he sitting here? Don't be asking a closed-ended question. So do I allow the patient to speak? There are studies shows that in field of medicine, only 23% of patients are allowed to speak, right? You allow the patient to speak for a few minutes initially. And again, within 15 to 18 seconds, sudden interruption is there. I'm going to focus on this symptom. போதும் நீ பேசுறது நிறுத்து, நான் பேசிக்கிறேன். Right? Listening. Right? Again, we tend to write the case sheet. We are in a worry. Next 40th minute, we have to go on present, or we will be bombarded. I have to complete. So listening. Why this listening is important? Being attentive or receptive. So apart from you gathering the information, you are gathering the information. For that, listening is important. One. Second, you are communicating to the other person that you are interested in this particular person. So the postgraduate is just looking at the case sheet and he starts writing whatever the patient says, the reason for consultation. I have to go, I have to ask these questions. What exactly is the patient is suffering from? The diagnosis, what question I have to ask. So if I am going to focus, the patient will not speak. Engagement will not occur. The next process of the interviewing process will be hampered. So how can listening be improved? So facilitative response. I am going to tell the patient that I have listened. Right? There are certain techniques which I am going to discuss, where repetition can be used, what is paraphrasing, and what is interpreting. Eye contact, right? We always write that there is no eye contact, whether for the patient or for the doctor, right? So, certain patients come and then they complain, sir, I met a psychiatrist. He was closing his eyes all the time. I don't know what exactly he is doing. So I told that probably he is processing all the information, right? We don't know exact. So the patient views all these things and they says, நான் உட்காந்து பேசிக்கிட்டே இருக்கிறேன், இவர் கண்ண மூடி தூங்குறாரா தெரியல சார். So again, eye contact. So we write that patient not maintaining the eye contact. Right? Whether doctor had maintained the eye contact, whether he is making eye contact, that is extremely important in initiating the session, that somebody is there who sits in front of me. He is there to help me. He understands me. He listens to me. So the listening skill extremely important is picking up the verbal and non-verbal cues. This is extremely important. What exactly the patient speaks, the non-verbal cue, what exactly the patient emotes, the restlessness, everything is a cue, and then you ask questions from then on. So you screen, right? You check with the patient. This is the initiation. Patient comes and then he speaks, he tells about certain problems. You screen, check with the patient that this is what you have told. Are there anything else you want to tell? And then you confirm this is what you've been saying. So this initiation is the screening process, sets up the agenda of the way you're going to travel with the patient. That is extremely important. So again, some people may say that how should I develop a rapport with the patient, sir? So one of the important thing is acceptance. So acceptance is not to agree. It is not agreeing with whatever the patient does, but it is accepting non-judgmentally and acknowledging the legitimacy of the patient to hold their own views and having their emotions. The feelings, valuing the patient's contribution. This is extremely important. So how I can show that I have accepted the response? How I can show that? So you can say by summarizing or restating or naming. For example, the second scenario, when somebody has come with palpitation and then he thinks about chest pain, you can just say, so you're worried about the pain might be caused by heart problem. Just summarizing what you told. Or you can say that patient has the right to feel or think as he does by using legitimizing comment. I can understand that you want to get checked out, rather than dismissing the patient and saying that எத்தனை வாட்டி பை ECG எடுக்கிறது. So use attentive silence. Again, this is extremely important. If you become suddenly silent for a prolonged period of time, the patient will become extremely worried, right? So appropriate non-verbal cues to make space for the patient to speak more. Why? Again, Suddenly the interview travels in a different dimension. He says that I am worried about getting the heart attack because I have lost my mom, 40 years of age, right? Because she died of heart attack. I am extremely worried that I also will die because of that. You have a cue here, right? Suddenly you should not say that, yes, but you will not get a heart attack because you are having a panic attack. Don't do that. So avoid the tendency of using a yes and but this is not that. No need to worry. And acknowledging the value of doctors of the patient expressing his views. Thank you for telling me. Right? So, it is very helpful to know your concern. So again, somebody who is extremely worried, who travels inside the hospital. So, the first thing is, am I safe here? That is the question which goes inside the mind of any patient who comes and meets a psychiatrist. And he also has various questions. What will he say? Whether I will be diagnosed with mental illness? Whether he will be willing to listen to me? Right? Will he be asking things which I don't want to do? These are all the questions which goes on, and how we are going to make a therapeutic alliance, creating a safe space, and how to go about with the interviewing process. So there comes the engagement. How we are going to engage with this patient. So it is ongoing sense of safety and respect. It's a process where in the interview it happens where the patient feels that this is a safe place and I will be able to share things to this particular person. So he is feeling confident enough, and then he shares the information. So another terminology is blending. So blending is a gauge where you can use that the engagement process has occurred. It can be observed how engagement has occurred. So why should I be worried about engagement? Why should I be worried? I have a set of questions I can ask that. But without engagement, you cannot elicit the database which you want to elicit and then travel on to the next phase of the interviewing process. Without the database, the whole process comes to a standstill. I will not be able to assess and diagnose. Then the patient will leave. So that the engagement process begins with empathy. One of my friends' statement, the first line, what is the size of your shoe? Right? So empathy consists of two parts. One is the cognitive aspect and the other is the affective aspect. Right? So you understanding and sensitive appreciation of another person's predicament or feelings, and the communication of that understanding back to the patient in a supportive way. It is a two-way process, and two things have to be done. You are communicating. Again, it has 4 or 5 steps. I am not going to the detail of what empathy is. So you can begin the process of empathy by simple things, by welcoming the patient, clarifying the patient's agendas, listening, facilitation of the interview, and then you express your thoughts to the patient, interpreting whatever goes into the mind, non-judgmental response and use of silence. All these things contribute to empathy. So you can make certain empathetic statements, right? So we can make that. So I can appreciate how difficult it is for you to talk about this. So there is a difference between an empathetic interviewer and who has identified with the feelings, right? So the empathetic interviewer has the ability to step back from his own emotions and can use his analytical skill at that point in time, not getting angry with what the patient says and then getting all the emotions in his mind. So there is no invested acceptance of patient's feelings in the clinician. So can I use empathetic statements to all the patients, right? There is a term called as strategic empathy. So when which patients, what time I have to use empathy strategically. So I cannot use empathy for all the patients. So we are going to see in which cases you cannot use, because empathy can increase the distance between the patient and the doctor. There are two terminologies. One is interpersonal stance, which is the psychological distance which the patient wants. What distance I will allow the clinician to enter into me, the mind, to my mind. The other is the empathic valence. The empathic valence is how intense you are going to ask questions about what's going on. So there are two types of patients. One is extremely trusting. The other group is guarded. So in extremely trusting patients, even a low valent or a low intense empathic statement may work. But if you keep on giving empathic statements to a patient who is guarded, say for example, the patient need not be paranoid or having a psychotic experience, but a person who has been brought to the OPD for involuntary assessment, somebody has given with the magistrate order, he'll be extremely restless and he'll be guarded, uneasy for therapy or negative transference or suspicious, then the empathy will backfire again. So in those cases, the patient is becoming paranoid. You are extremely empathetic with the patient with paranoid delusions. Again, it goes in for a paranoid spiral and then the patient will recede and then he will not talk. So it goes in for a stony silence. So how am I going to break that empathy? Don't keep on giving an empathetic statements, but use pure reflecting statements what the patient says. Just reflect on what he says. The same statement what he makes and then you go on. So again, when any other patient is extremely in anger and then you diffuse the statement that just making a statement that it makes sense that you are extremely upset. Just the emotions what he feels and then you diffuse by making this sympathetic statement. Then we come to the next part, gathering the information. So if we start gathering the information in a highly controlled style, which is the process, and if you focus on the symptoms, premature focus on the symptoms, which is the content, and then this particular narrow approach will limit the patient's ability to communicate their own feelings, and then it gets stuck. So when you gather the information, there are three roles. One is you explore the patient's problem to discover the biomedical perspective. You ask for the patient's perspective, what is his views, and the background information of the patient, and also ensure that the information is gathered, is accurate, complete, and mutually understood. Again, establishing a common ground with the patient and the clinician. So in this particular gathering the information, apart from the patient is listened to, there is a collaborative relationship that is being developed with the patient. So the weakness of the traditional medical history is we always talk about extreme objectivity, we miss the patient as a whole, the patient's perspective. I'm talking about the patient's perspective. So one of the issues with the traditional medical history. The premature search for scientific facts that stop us from listening, that prevents us from both taking an accurate history and picking up the cues to our patient's problems and concerns. The disease-centered medicine so quickly turns into doctor-centered medicine. It will be detrimental to both of us, the patient as well as the clinician. So Mishler talks about two parallel monologues. The doctor will speak about his own thing and the patient will be speaking about his own perspective. So we have to, as a clinician, we have to take all these things, both the biomedical perspective as well as the patient's perspective, and then we have to integrate the last line where the stage label integration occurs so that it will help in the explanation and planning. We have to integrate both the perspectives, the biomedical perspective as well as the patient's perspective. It should not be two parallel monologues, it has to be integrated. So we back and forth both these frameworks and integrate and then come to the explanation and planning. So the process skills here, the skills which is necessary for information gathering, I'm not going to talk about anything about content. It's what the patient says, the patient narrative, the questioning techniques, which will be briefly I'll discuss, open-ended and closed-ended techniques, and where we should use open-ended and where we should use closed-ended techniques. And listening, we have talked about it. So facilitation, response, and other things I'll be coming in and briefly, how to increase the response of the patient verbally and non-verbally. So you can make clarification, right? So could you please explain, when the terminology is very vague, what the patient says, just clarify with the patient by making a question. And you have to use time framing, where the last part of the slides I'll be discussing about what is anchor statement, how we are going to discuss. So many students have problems with time framing. When this has happened, when did he start drinking, when did it occur? So how we can ask the time framing by giving cues to the patient by asking an anchor question. So last thing is internal summary. There are two things. One is the last end summary where we make, when we present a case to the examiner, we summarize, right? But we have to summarize two times to the patient. One is the internal summary when we gather information and then summarize to the patient and check whether he has understood what you are told and we have understood what you are told and we have left anything. The last end summary we to the patient also. So again, the patient's perspective, you have to gather information about his own idea about the illness, his concerns about the illness, his expectation, and his feelings because I'm having a chest pain, what are the feelings I have? And what effects the illness has upon me. All those things, the 5 things have to be recorded. So open-ended and closed-ended, and then many a time we start with a closed-ended question. So we ask 1, 2, 3, 4, 5 closed-ended questions and then the patient will not speak. He will get stuck. So always start with an open-ended question. It's a divergent technique. Make statement. Tell me more about that. Tell me more about what you've been going through. So the most common thing is a closed-ended question. It's like a cone. They say that they metaphorically say that it's a coning technique where you start with the open-ended question, then go on the closed-ended question when you want to ask about the content part where you are asking about the symptoms. So the advantages of open-ended question is, apart from you gathering the information, it encourages the patient to tell his own story and it prevents the stab in the dark. Nama irutla ukkandu kathi suthittu irukra mari illamal you are very clear at that time. So it is extremely effective for diagnostic reasoning and then exploring both the disease and illness aspect. This is extremely important. So you are exploring both the disease aspect and the patient's perspective or the illness aspect by using the open-ended questioning method. So open-ended is again a continuum. It ends with the closed-ended. There are variable questions here. I'm not going to go into the detail. You can take the slides if you want. The variable questioning, you have empathetic statement and facilitating statement and swing questions. So how can I facilitate the response from the patient? By encouraging silence, I've told, repetition, paraphrasing, and sharing your thoughts. So you can use silence effectively. When should you use silence and how many minutes you have to be silent? So repetition or echoing, you can just repeat the last few words of the patient when he makes a statement and encouraging the patient to keep talking. Paraphrasing is you are restating in your own words the content and the feeling of what the patient has given. And this skill is extremely important because apart from what the patient says, it delivers to the patient that you have understood correctly or not. So you can share your own thoughts. The second scenario, chest pain, the patient comes with chest pain. So you can say that sometimes the chest pain can be brought about by stress. I was wondering if you felt that might be true for you. So the internal summary, again, it's very, very important for future response of the patient. Attaining the mutually understood common ground, the summary is important. So we are going to discover the patient's perspective. One is directly asking the questions and picking up the cues. So again, coming to the structure of the interview, the next part. So in the structure, the second line, the doctor controls the shape of the interview. That is what is happening in a traditional interviewing technique. But to shift that power, you have to have a concept of collaborative partnership. So you have to collaborate with the patient. There are times where the patient controls the interview. Patient keeps on talking about something. He is controlling the interview and then we have lost the ship. He is going to be the captain and then he is going to take the ship somewhere. So many a time the doctor controls, it's going to be extremely rigid. He has the power balance and then we are going to shift that power balance to going for a collaborative partnership, equal relationship between the patient. So it should be flexible and ordered. Patient to be understood and encouraging the patient to be a part. You have to encourage the patient to be a part, to participate and collaborate. And all these things for effective and accurate information gathering and efficiently managing the time. That is extremely important. You structure the interview in such a way that you manage the time efficiently. So So how am I going to structure the interview? One important thing is the signposting. Signposting, you've been seeing a signboard here. The sunrise point is 1 kilometer from here. So the post is there, signboard is there. So you signpost to the patient, tell the patient that I'm talking about this thing now, I'm going to speak about this thing now, signpost, and then you move on. So summarizing and signposting, these are extremely important skill in structure of the interview. This is what I am going to speak. So that gives the entire structure. This is a very key and important skill for collaboration as well as interactive interviewing. So it gives a structure and the patient feels understood. So coming to the explanation and planning, the first scenario and the second scenario, right? So the first scenario is somebody has come with he skips the medication and he comes, right? The third scenario is somebody is being started with the lithium, being diagnosed with bipolar depression. So when you give an explanation about the illness or about starting a medication, so again, you have to gauge the patient, what kind of information, what amount of information, and how you are going to give the information. This is extremely important, right? So the providing explanation that the patient can remember and understand, whether he is able to remember what you say and whether he is able to understand. Just like that, don't give all the information which is there in the Kaplan and Sadok or in Tasman or in Oxford textbook of psychiatry. Providing explanation that relates to the patient's perspective, right? You are going to translate the medical information into the patient's language. Before that, you are going to assess what kind of information can be given to the patient and then his own perspective about the illness, and you are going to take into account all these things and then you are going to explain. So it is an interactive approach, right? Most of the time, the matra, saapdu, seriyadum. Evlo naaliki, again you know the statement what we say, right? Using an interactive approach to ensure a shared understanding of the problem of the patient, involving the patient with planning and collaboratively, right? Planning the management plan. All these things to improve the patient commitment and adherence to treatment, right? Before we scream at the OPD, when the patient is refusing medication or patient is discontinuing medication, again these things are very important. So there are two methods. One is a shot put approach, right? Shot put தூக்கி போட்டோம்னா அங்கே போய் விழுந்துரும், அவ்வளோதான், முடிஞ்சு போச்சு. The second approach is important, where is the frisbee approach, where you throw the frisbee, it comes back. It goes to the person and then it comes back, the other end. So this frisbee approach is extremely important, where mutually understood common ground is necessary for foundation for both trust and accuracy. Achieving this common ground is one of the central concepts in the explanation and planning process. This is again important. Rather than giving all the information, you chunk and check. You cut it into pieces and then give the information, and then you check whether he has understood what you have spoke. Again, it's interactive, incorporates all the things what we spoke. So repetition. You can use repetition in explanation planning, right? You given information and then you can ask the patient to collaborate. So somebody who has gained weight on medication. So you can just say, I have given you a lot of information about what are the measures you have to take and what are the reasons for weight gain. It would be helpful to me to hear your understanding about weight gain and what are the treatment options you think might work. So tell back directive. It is again asking the patient to tell them what I have said, what exactly information I have given in my own words. So you should not use any medical jargons when you give information to the patient, or when you give a jargon, when you use a terminology, explain that this is this, right? This is what I am meaning, because the person who sits in front of you will not know about the medical terminologies. So again, explanation planning, do not give an one-sided speech, which usually occurs. Two-way interaction process, which is extremely important. Encourage the patient to ask doubts. Just ask a question, do you understand? Do you have any other questions? Do you have any doubts regarding the informations what I have provided? And seek clarification for a shared understanding. So, whether the plan and the explanation is to the patient needs, that again is very important. So, coming to the closure, we don't close the interview at all. For 2 hours or for 4-5 hours, the patient will be sitting from 8 o'clock in the morning till 1 o'clock in the afternoon. Right? The intern will take the case for 45 minutes, 1 hour. Then they will go and discuss the case to the consultant, assistant professor, the faculty. It will take 2.5 or 3 hours. And suddenly comes and gives a prescription and send. Thank the patient, right? So we had a learning experience. We have got a lot of information with speaking with the patient. Thank the patient, and then the extreme important thing is you have to establish the plan and confirm and establish a plan, and then talk about the various things. Any contingency plan we have to make with the patient. What if the patient relapses by consuming alcohol? What are the things we are going to do? And then about the patient's adherence, the outcome of the illness, all those things. The closure is extremely important, which we don't do it. So that 1 or 2 points about motivational interviewing. I'm not going to go into the detail where the collaborative partnership or the process is is a central theme of motivational interviewing, where we empower the patients to take responsibility for the decision by respecting their views and concerns, by negotiating suitable targets and right. So coming to the last part, I'll talk about 4 or 5 issues. One is a hotspot situation which usually occurs. The hotspot, the patient might be extremely angry at times, disinhibited, over-familiar patients, threatening or upset. So what we can do is helicoptering technique. So helicoptering technique is a technique where you helicopter hovers around and then it moves, right? So when the patient says that, doctor, I'm extremely agitated, restless because I've been taking diazepam, I'm sleep disturbed, my sleep is disturbed, I've discontinued diazepam, I want diazepam. Just acknowledge that I can understand that you are extremely anxious because you haven't taken the medication, but before prescribing, I want to ask a few questions. So you helicopter around to maneuver the hotspot situation. So you listen, you acknowledge the emotion, reflect, summarize, and redirect the conversation. So there are 3 areas in problem interview: shutdown interview, rehearse interview. So shutdown interview, the patient does not speak. At times the reason is probably the interviewing technique what we use. So again, so to break the shutdown interview, you can go in for open-ended verbalization or give commands. Wandering interview, when the patient wanders, speaks on tangentially speaking, again you can go on just by gentle structuring. You just speak to the patient that I would like to focus on this particular issue now, right? And then direct the interview. Rehearsed interview. Somebody comes with a chronic mental illness who knows about the system, who talks about various things about the diagnosis and other things. To break that rehearsed interview, you can go in and ask about the history of symptoms and then going for an affective interjections like asking affectively charged topics and then take control of the interview. So 2 or 3 things about how to, techniques to gather the sensitive information. One is to generalize recall, talking about anchor question, which is focused on location or time. When you ask about, say for example, somebody has, when did he start drinking first? So just have a timeline, fix the timeline and then ask an anchor question. Tagging question, when somebody says that I've been taking a lot of medications for antidepressant, just giving, these are all the antidepressants, which medication you've been taking, do you remember which medication? That is a tagging question. So techniques for avoiding miscommunication, when the patient says that I've been always depressed, then you can define the technical term of depression and then you can say that this is what depression is. Have you had all these symptoms? And then going about clarifying. Normalization, again, very important technique. Say for example, your patient is extremely depressed and then you can ask, sometimes it's not uncommon in people who have been having low mood to have thoughts of harming themselves. Do you have any thoughts of, dark thoughts of harming yourself? That is normalizing. You are normalizing that these things can happen in people with depression and the patient can come out with suicidal ideations. Shame attenuation. Attenuation is decreasing the shame and getting out the answers from the patient. So when asking about suicidal ideation, you can say that with everything going on, have you been having any thoughts of killing yourself with all the things going on in your life? So behavioral incident, you can ask about fact finding and other sequencing behavioral incidents. 2 minutes, sir, I'll complete. So specific fact finding questions. Say for example, somebody has a seizure. So you just ask what happened at that point. Sequencing behavioral incidents. What happened before the seizure? What happened after the seizure? So gentle assumption, other things I'm not going to go into the detail. So simple amplification is again important. You know the patient has been consuming alcohol, he has been consuming alcohol coming to the OPD, and then he is very reluctant to give the quantity of drinking. Again, symptom amplification is, you have evaluated the patient is extremely jittery, restless because of the withdrawal symptoms. You just ask him, yes, I consume. How much do you drink? I don't drink more. நான் நிறையலாம் குடிக்க மாட்டேன் சார். எவ்வளோ குடிப்பீங்க? இல்லை சார், நான் நிறைய குடிக்க மாட்டேன். You just ask him 2 or 3 or 4 quarters of alcohol. So go to the maximum limit so that he can say that, yes, 3 quarters of alcohol. So the last thing which I want to talk about is clustering, where clustering is extremely important. When you pick up a queue and the patient speaks about, I'm hearing voices, you ask about all the qualities of hallucination before moving on. That is clustering. You cluster all the profiles of that particular phenomenology and then you move on. This is the last slide. So people always say that I want to be a good interviewer. How should I do it? Osler's word is practice, practice, practice till you die. Thank you.
Aravindan for his extensive talk on interviewing skills. Now I invite questions from the audience. Questions please. 5 more minutes.
It's not a serious question, Dr. Aravindan. Very nice presentation. Just I want to tell them about the importance of any notes taking during the interview, because that is allowed in certain situations and it's not allowed in certain conditions. So please highlight on them. Taking notes, because we may forget what the patient is telling. So during the interviewing of the patient, are we allowed to take notes?
So we can inform the patient that when you speak, I can take notes. But when the patient is extreme, say for example a situation where the patient is guarded or paranoid, and then you start taking notes, you are not looking at the patient will feel that it is not safe. This particular person is doing something. So just inform that it will be confidential, the information will be kept, the record will be confidential, and then this is what I'm going to do, this is what I'm going to write, whatever you are saying, it's going to be confidential. So without informing that I'm going to take notes, but nowadays it's all electronic, and then we keep on typing and not looking at the patient, writing system is there. So we can tell the patient that what we are going to do. This is what I am going to do. This is for such and such a thing. So you need not worry about this. This is going to be extremely confidential. So initial analysis, what goes into the patient's mind. So viewing from their side, what they feel. So note taking, we have to inform to the patient what. Very difficult for me to do an MCQ from this session. So in the explanation and planning phase of the interview, which approach is used to attain a mutually common ground? Next one. எல்லாருமே சொல்லிட்டாங்க சார்.
Everybody will get a pen drive.
To overcome paranoid spiral and to break stony silence, what will you do? Reflecting statement.
Name?
உங்க பேரு சார்.
In psychiatric knowledge and skills, there are 2 components. One is explicit and the other one is implicit. So explicit you can learn from textbooks, you can learn simply, that is a conscious learning. The other one is unconscious learning, and it is an implicit knowledge which you can acquire only by seeing your seniors, teachers interviewing your patients, and it is get imbibed in you by social learning or observational learning without your knowledge, without your conscious awareness. I think I am very glad that Dr. Aravindan has tried with his, has made with his long experience and teaching, what to say, skills. He has thrown extensive light on the implicit knowledge which you have to acquire over the period of 3-4 years by observing your teachers and your patients. So I am very happy that Dr. Aravindan has done that job extremely well in teaching the nuances of the interviewing skills in psychiatry. Now I request my co-chairperson to conclude the session. Thank you very much.
So, as I told, sir, given a new perspective in interviewing technique in psychiatry, definitely I hope this might be a eye-opening for all postgraduates. Thank you very much.
So medicine is both an art and a science, and psychiatry is more art than so. And no other person other than Aravindan is Dr. Aravindan is apt, as is a more humanistic and person, and he is also an activist that our postgraduates should learn. And with that, we conclude the session. I request the chairpersons to honor Dr. Aravindan sir.
I invite Dr. Kumaran sir to honor Dr. Malayappan sir. And I invite Dr. Anand Kumar sir to honor Dr. Sivabalan sir. We call the winner to the stage.